Guests gathered here for a great session today. Wow, a wonderful evening. I welcome on behalf of Cadila Pharmaceuticals to all of you. My name is Bharat Rajani. I'm working in the capacity of AGM for the organization. Thank you very much. And on behalf of Cadila Pharmaceuticals, I welcome all of you for the session, which is on a very, very important topic, which is antibiotic stewardship, optimizing clinical use of novel carbapenem. So before starting the scientific session, I would like to introduce our Senior Vice President, Mr. Rana Brata Bose, who is there with us. So welcome, sir, for this session today. So before the session starts, sir will be just giving you the brief about Cadila Pharmaceuticals as an organization. Thank you so much. Hello.
Yeah. Good evening, doctors. First of all, thank you very much for being over here. We all welcome you on behalf of Cadila Pharmaceutical for Maxima Division for this great launch of Bapogret, our new biopenem, which we have just introduced in the market. And before we go ahead, Bharat, is it okay, hi. So, it's fine. Just list it. Yeah, sorry for the interruptions. So what I was just telling that before we go ahead with the presentation from Dr. Chawla, what I'd just like to have take an opportunity to revisit Cadila, because I know all of you have been actually been engaged with Cadila since probably from last good 30-40 years, 20 years, as per your the profession which you have been working for. And I believe Cadila has been one of the house which has been there in the industry for last good 71 years. It was established in 1951 by late Dr. Indrabhadan Ambalal Modi, and now presently being taken care by Dr. Rajiv Modi and his son Dr. Rajiv R. Modi. We have been there in the market since 1951. There are some definitely brands which are there, which is known to every one of us. Maybe if we talk about Aciloc, Vasograin, this kind of flagship brands are there. We have 5 different manufacturing plants, almost 7,000 plus global employees. We operate in 100 different countries, and we have almost 900 plus brands, and which actually contributes to so we have a bigger field force in terms of international operations also, where we have got almost 200 products across the globe in 100 different countries. If you have all seen in last few of the months, Cadila actually is now transforming to a different entity. Cadila has been expanding into different geographies, not only geographies, into different part of the medical part. That, like, we have this particular division called Maxima, which is basically into part of critical care, part of chest, part of respiratory ailment products. We are actually strengthening our portfolio over here. So in that way, today we are around 17 divisions which are being there in Cadila. Across the verticals, we are working in Indian operations around 1800 crore plus company. So this is what about Cadila. And without wasting any other time, I just request Dr. Rakesh Chawla, who doesn't need any introduction actually, to come and address and actually take us all through the novel biopenem, the novel carbapenem, which is being launched with a brand name called Bapogret. So with this, I request Dr. Chawla, please come and address the entire audience. And this meeting is also being telecast across India, webcasted across India. So there are online doctors also who are actually attending. So it's a humble request to Dr. Chawla, please, sir.
Thank you so much, Rana sir, for giving the introduction for the topic as well. As sir has said, I would like to invite Dr. Rajiv Diban and Dr. Ram Babu to be a part of this session, sir. So as All of you are aware that the speaker and the moderator for the session is Dr. Rakesh Kumar Chawla, who is a senior consultant, respiratory medicine and critical care, sleep disorders and interventional pulmonologist. He is working as chairman, Department of Respiratory Medicine, Critical Care and Sleep, and chairman FUS program at Saroj Super Specialty Hospital. Working as senior consultant, Department of Respiratory Medicine, Critical Care and Sleep Disorder at Jaipur Golden Hospital, and as a senior consultant in sleep disorder at Rajiv Gandhi Cancer Institute and Research Institute. There are a lot of things which we can say about Dr. Chawla. He's pioneer and there's a maximum cases of endobronchial placement of glue in cases hemoptysis in India. Dr. Chawla has been confirmed with appreciation award by Honorable Dr. APJ Abdul Kalam of Rare Lung, Airway and Pleura Disorders, World Association of Bronchology, Interventional Pulmonology. Dr. Chawla is recipient of prestigious OA Sharma Oration of Indian Chest Society at NAPCON 2015. He is a member governing council Indian Chess Society and is elected journal chairman Indian Chess Society. Dr. Chawla is recipient of prestigious AS Mental RCJ Innovation of NCCP at Ahmedabad NAPCON 2018. He is recipient of prestigious COVID Warrior Award of Indian Medical Association on 1st of July 2021 and COVID Warrior Award of Delhi Medical Association. A lot of things to be said about Dr. Chawla. So with this, I will invite Dr. Chawla for today's session to start with, sir. Thank you, sir. Exactly, sir.
Yeah, absolutely.
Thank you so much.
Thank you for the humble introduction. I am obliged. So, the molecule is walking into the country new. All of us have not much experience about it, but yes, this kind of a scientific programs will make us aware of the newer things which the pharma industry is introducing into the country. There is no clash of interest. Right. We know we are going to talk about the antibiotics. So the microbes, and before I switch on, I thankful to Dr. Ram Babu and Rajiv Diwan agreeing to moderate the session. Microbes have been around longer than anything else on the earth. Microbes became so good at survival that they have continued to live on the planet till today and are present everywhere. And they know these human beings are going to commit mistakes regular, and they are going to grow gradually and gradually. They are 3.5 billions when humans are 4.5 millions. So you can see the evolution of these microbes is much before than now. Bad bugs, no drugs, and you cannot escape from the organisms Enterococcus, Staphylococcus, Klebsiella pneumoniae, Acinetobacter, Pseudomonas, Enterobacter. And when these organisms in unresolving pneumonias or septicemia or ventilated associated pneumonia get organized into the lung, or they make the houses in the lung small, this is the most difficult and challenging situation for anybody who is working in ICU care. You are using all kind of permutation combinations, all kind of things are going on, and you get the MDR organisms, then you get the XDR organisms. No antibiotic works, and this is the most difficult situation. So you need a newer molecules, newer things to come to help you. What is an antibiotic stewardship? This refers to a set of commitments and activities designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic resistance. So you have to have the right drug, you have to have the right person, you have to have the right time frame when you are using these antibiotics. Antimicrobial stewardship team is infectious disease clinician, infectious disease pharmacist, clinical microbiologist, infection prevention control committee, information system is the ideal stewardship team. And if we introspect our hospitals, do we really have this kind of a team where we are treating our critical care patients? The antimicrobial stewardship is comprised of 4 Ds: right drug, right dose, dosing interval, and the right duration. Prospective audit with interventions and feedback, formulary restrictions, switch from parenteral to oral, streamlining and de escalation, infection control, appropriate use of microbiology lab, and other strategies to make this stewardship program strong so that we get minimum of the antimicrobial resistance, and our antibiotics should bail out the patients who are fighting for their lives. How this develops? You have the sensitive population. Among sensitive, there are few resistant organisms. They survive. Once you are giving the antibiotics, they know how to eat this antibiotic and become fat and become strong. And finally, they start transmitting this by mutation. The antibiotic resistance is transmitted from one microbe to another, and the resistance develops and they take over the patient, and nothing works at that time. Use of inappropriate antibiotics, misuse of antibiotics, inappropriate drug for the disease. Now you are working in an ICU. You must know the ICU flora. You must know your antibiogram. You must know your bug. You must know the local sensitivity pattern. Accordingly, you use the antibiotics. So antibiogram should be released by the microbiologist every month, which is, I am sure, maybe it is All India Institute to the Medanta to Escorts or any hospital. Nobody follows it. Let it be the best institute of the country. Nobody follows, we talk. But antibiogram policy by microbiologists should be so strict that every month, and he should be the policeman. He should be, microbiologists should be on the round with the clinicians and consultants who are finding difficulty to isolate the organisms. Patient is sick, patient is febrile, patient is not responding to the antibiotics, and all cultures are coming sterile. Blood is sterile, urine is sterile. You take lavage specimen is sterile. Now what clinician will do? He knows his patient is sick. TLC is going up. Cultures are all negative. What he will do? This is where the microbiologist, his lab helps. So it's very, very important when you are taking a critical care unit round, the microbiologist should be a part of the team of taking round and should realize the difficulties. The problem is we are busy, we go away, he is busy, they go away, they keep on typing and printing the reports and keep on feeding to the system, which is of no use to the consultants. So it's a very, very important part of the stewardship program, and microbiologist is very, very important in the system. What we are creating monsters: methicillin resistant Staph aureus, Carbepenem resistance Enterobacteriaceae, deadly resistant to almost all antibiotics. There was a time 5 years, 6 years before when your patient, the bug is sensitive only to colistin and tigecycline. So they were the antibiotics available, and after that there is nothing. Then you came to phosphomycin. And these are the antibiotics which are not tested of the time. Polymyxin B, they are fired in a desperate situation, making permutation combination. शायद patient ठीक हो जाए, putting an antifungal, adding an antiviral, adding an antibiotic, putting all expensive things in the same basket. And you are on a losing ground because you are heading without any target, because the cultures are not supporting you and you are fighting a very difficult situation. So like Pseudomonas aeruginosa, as I said, most dangerous, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter, difficult organisms to eradicate. Human use began in 1940. Alexander Fleming, he discovered the first antibiotic, penicillin, and won the Nobel Prize. And he predicted antibiotic resistance, and this is what is happening today. The rule of 30, the 30% of all hospitalized inpatients at any given time receive antibiotics. Patient is admitted and patient is on one or the another antibiotic. Over 30% of antibiotics are prescribed inappropriately. 30% of all surgical prophylaxis is inappropriate. 30% of hospital pharmacy costs are due to antimicrobials. 10 to 30% of antimicrobial cost can be saved by antimicrobial stewardship program. But our law, land of the law, our MCI, our NMC, they are so strict. If physician is not using them, he can be taken for a ride while you waited for antibiotics to start and you did not wait for the culture reports. Why you did not start empirically? So there are so many things of the law, legal system, which forces the physician to start the antibiotics upfront, which should depend on the local antibiogram policy. So the physicians, the legal system is so difficult to deliberate. It's very difficult not to use and use. Stewardship says that you do the culture sensitive, send it immediately. And it takes 24, 48 hours for the reports to come, and choose the group of antibiotics which you are going to use. And another group of thought will come, why you wasted precious 48 hours? Why you did not start up front? So this, what they talk about 30% in the literature, it's again a debate. So 4 movements of antibiotic decision making. Does my patient have an infection that requires antibiotics? Have I ordered appropriate cultures before starting antibiotics? A day or more has passed and can I stop antibiotics? What duration of antibiotic therapy is needed for my patient's diagnosis? So right drug, right dose, right interval, and right duration is the most important thing. Then duration. How many days you should use an antibiotic for an infection? So uncomplicated UTI for 5 days, community-acquired pneumonia 7 days, ventilated-associated pneumonia 8 days, coagulate-negative staphylococci 7 days, acute osteomyelitis in children 21 days. So this is how you choose the number of days to use the antibiotics. When you will switch from parenteral to oral, your patient is stable, hemodynamically is stable, he has started taking orally, fever has subsided, WBC has settled, vitals are stable, yes, then you will be changing the IV to the oral formulations. Antimicrobial stewardship program will help the quality of the patient care, patient safety, reduced treatment failures, increased frequency of prescribing appropriate therapy, reduces the C. difficile infection rates, reduces the antimicrobial resistance. Global deaths attributable to the bacterial antimicrobial resistance in 2019. E. coli, Staph aureus, Klebsiella pneumoniae, Pseudomonas, and Acinetobacter have been the prime cause for the mortality. Intensive care unit infections, again, there is a major concern for the clinician, for the multiply of resistant bacterial strain. How many times our ICUs are fumigated? How many times our ICUs are really cleaned? Because the profit, the expenditure, the business attitude of the hospitals, that doesn't make bother the owners who are not clinicians. So the business should run. Inside stories are very, very bitter. Do any ICU, and our ICUs are open, they doesn't have any negative ventilation, so that automatically the bacteria or the system is going out. And no one has time to clean, fumigate their ICUs, because if you have a 30-bedded ICU, think of a loss for 1 day in a private corporate system. So nobody is bothered. We talk. Do we really practice? That is very, very important. There is an EPIC study, which is a point prevalence study, in which 1,265 ICUs were taken, and it was a cohort of 13,796 patients, which were having mean SOFA score of 6.3. 28% were medical patients, 72% were surgery, and 56% were on mechanical ventilation. Gram-negative pathogen were more common in Asia as compared to Europe, US and Europe. If you see the percentage-wise, you will see these all gram-negative, E. coli, Acinetobacter, Enterobacter, Pseudomonas, they are predominantly more in Asia rather than Europe and US. The majority of ICU infections are due to gram-negative bacteria. 70% of infected patients had positive culture, in which the 62% were the gram-negative organisms. The organisms which are causing complicated UTI or the intra-abdominal infections or pneumonia, again, are the same group of gram-negative organisms which are revolving with each other. The MDR gram-negative organisms, approximately 10% of the patients are resistant to these organisms. Now, carbapenems. They are active against streptococci, enterococci, enterobacteriaceae. Ertapenem is not active against Pseudomonas. They are used for sepsis, HAP, VAP, intra-abdominal sepsis. The pathogens like polymicrobials, ESBLS, Pseudomonas, and Acinetobacter, and the another group of the organisms which are coming up and propping up, and already they are resistant to the antibiotics. There is a rising resistance in India. Even they have done the far off places like Mizoram, where 11.3% resistance have been found. Now, carbapenem resistance in gram-negative bacilli, Pseudomonas, Acinetobacter, and Enterobacteriaceae. And if you see, the resistance to imipenem was found in 28% of E. coli, 55% of Klebsiella, and 80% of Acinetobacter baumannii. So it's a matter of concern, because when the things are coming to the level of the carbapenems, any physician who is losing a better will immediately please start the carbapenems in combination with other antibiotics, so we are able to bail out the patient. And even in US, 15 to 22% of Pseudomonas aeruginosa and 21 to 48% of Acinetobacter are carbapenem resistance. Don't think US, Canada, Europe is anyway different. If you really want to see the system, they are more worse than us. Same story everywhere. We think here, they follow these things, they follow these things, end of the day, all is the same. If you will have an opportunity to visit all hospital, if you go and visit some conference, take an attachment that I am coming, I want to visit your hospital. They are not like our system. They are more than enough. They are there to wait for you. They will make you see their ICU, what they are practicing, how they are practicing, and you can visualize what you are practicing back. So things are there. They are also not perfect, but they are developed. So we look upon them. Yes, they are following the guidelines. They are following this, but definitely the surveillance programs, stewardship programs are little more strict than what we do. Mortality is very high with the inadequate therapy, and inadequate carbapenem therapy definitely leads to mortality. Carbapenems play a critical role in our antibiotic armamentarium. Carbapenems possess the broadest spectrum of activity against potency to gram-positive and gram-negative bacteria. Due to extended spectrum beta-lactamases producing organisms, the increasing resistance challenges represented by beta-lactamases, carbapenemases, and carbapenems still assume a great role in treatment of serious infection. We cannot dismiss them, but yes, still the organisms are more notorious. They will produce the enzyme which will destroy your antibiotic. So why we need a newer carbapenems? Because of the high mortality, morbidity due to the lower respiratory tract infection, complicated urinary tract infections, inadequate initial treatment results in increased clinical failure rates. Pseudomonas aeruginosa continues to be among the most prevalent organism and is multi-resistant. The early carbapenems like imipenem are not stable to hydrolysis by human renal dihydropeptidase DHP1, and therefore co-administration with DHP1 inhibitors like cholecystine, like you are using amoxicillin clavulanic acid. Amoxicillin alone is useless. You are using with clavulanic acid as a catalytic agent to make its effect. But this molecule, which we are going to talk, does not need any support. It itself is inhibitor of DHP1 enzyme in the kidneys, rising resistance to existing therapy options. So today's meeting has been called to introduce this new molecule to the country. It is Carbapenem. It is not new to the world. It is new to the country. And our DGCI has approved for the management of complicated urinary tract infections. But this biopenem, bearing a triazolim thioether substituent, shows increased stability towards metallo-beta-lactamases, which are implicated in carbapenem resistance. Unlike imipenem, biopenem has one beta-methyl group at C1 position, conferring stability. As I said, that this is the position where it is there, and it makes it more stable, and it is not hydrolyzed by DHP1. Now, whenever an antibiotic is pumped into the organism is very smart. Either it will eat away and destroy it, or it will throw it out of the cell wall, or it will make multiple copies that you cannot deceive the organism, and antibiotic they escape, or they will create a site where antibiotic will go and he is not able to work for the antibiotic. This antibiotic is resistant to the efflux by the organism. It has a stability, as I told you, for the renal brush border enzyme DHP1. It has a low convulsive potential than other meropenems. Spectrum of activity is the all gram positive aerobes and all gram negative aerobes. It is effective. It is another carbapenemase. Is as good as meropenem or imipenem celastin in combination. But you have another carbapenem which is effective for all broad spectrum antibiotics. And this molecule has a protein binding percentage of 4. So drugs, they are minimally protein bound, penetrate tissue better than those they are highly protein bound, like you have the meropenem and you have the imipenem celastin. DGCI, as I've told, has approved it for UTI, complicated UTI, but internationally in Japan, in other countries, it is used for sepsis, lower respiratory tract infections, pneumonia, pulmonary abscess, complicated UTIs, intra-abdominal infections, peritonitis, and uterine inflammation and infection. So it is a broad spectrum carbapenem which can be used in any of the indications where we are using meropenem or imipenem celastin. Its dose is 300 milligram twice daily, administered as 30 to 60 minutes in an infusion. It's available as a single 300 milligram vial and must be reconstituted in 100 ml of 0.9% sodium chloride. Dosages can be adjusted as per the individual and as per the renal parameters. You must monitor and administer biopenem carefully, reducing the dose, and hemodialysis patients should receive it once a day. And those who are taking valproic acid, so that it has to be seen the level of valproic acid will reduce and patient will have the chances of seizure. So that dose has to be adjusted. So evidence of biopenem from clinical trials and meta-analysis in the phase 3 trials in Indian patients, it is non-inferior to imipenem and celastin on head-on trial. So it's equally superior where we are using meropenem and imipenem celastin. And it is equally efficacious as meropenem. A safety profile is also comparable because all of us have a vast experience of meropenem. We are confident of using meropenem, even not that much imipenem celastin, because seizure is much more with imipenem celastin than meropenem. And meropenem is used whenever the physician is struck. He knows कि मुझे meropenem in combination with gram positive or in combination with other gram negative antibiotic has to be picked up and to use it in combination. So this is another molecule which is talking of that it is also equally good as meropenem. So there are 8 RCTs which speaks of its strength. So there are patients who are 1685 of lower respiratory tract infection, complicated UTIs and complicated intra-abdominal infections. And it had a similar clinical efficacy and microbiological success to imipenem and meropenem. Biopenem has a high safety and is well tolerated. Biopenem may be a valuable option. Biopenem to be more potent than imipenem against Pseudomonas aeruginosa. Carbapenem and other antibiotics, it's Carbapenem has got lower rates of side effects. This we will come to know when we will start using the drug. It is as safe as meropenem. So Carbapenem for community-acquired pneumonias, it is effective in say 69.2% of cases and is effective in 90.9%, 90% with previous diagnosis of COPD, asthma, bronchiectasis, or pulmonary fibrosis. So it's a very safe and an effective antibiotic. Carbapenem shows a good post-antibiotic and has a high bactericidal activity against the another phenomena of biofilm formation, which the bacteria have learned to dodge the antibiotic, is a forming of the biofilm around its own wall. So it is able to break that biofilm to make the organism die. So in vitro activity of Carbapenem and comparators against MDR and Carbapenem resistant Acinetobacter baumannii, again Carbapenem showed MIC of 50 by 90 of 1632, which were at least two-folds lower than imipenem and meropenem. So the lower the MIC, more effective the antibiotic. Carbapenem and meropenem on valproic acid, again the level of valproic acid get altered less with Carbapenem than with meropenem. Again, if you are using this drug in combination with colistin or fosomycin, they all work in synergistic and they are more effective against the organisms. Carbapenem is very active against Boltera pseudomyli, and Carbapenem could be an alternative therapy for milioidosis. Again, it's very safe than piperacillin tazobactam and is very effective if you are using against piptazole. Again, clinical efficacy and safety of Carbapenem for febrile neutropenia. It appears to be promising an initial stage therapeutic agent in patients with febrile neutropenia complicating hemopoietic disease, and was demonstrated to afford prompt clinical benefit in these patients. So you can say the patients who are immunocompromised, who are fighting with cancer, especially the cancer institutes, they can find this molecule to be more useful because they are the patients who get into more and more neutropenic and they are immunocompromised. Degradation, as I told you, the DHP, it is resistant to the degradation enzyme which is produced in the kidney, and this where it scores over meropenem. Drug-drug interactions are important and safety issues when inhibitors and substrates of the drug transporters are administered simultaneously, and Carbapenem had a lower affinity towards organic anion transporters than meropenem. So the drug-drug interaction, for our understanding, is very low as far as Carbapenem is concerned. Special features and properties, what makes it special are the greater bactericidal effect than other carbapenems against Pseudomonas, greater bactericidal effect against Acinetobacter, established clinical efficacy and success rate to imipenem and meropenem, more stable than imipenem and meropenem to hydrolysis by human renal DHP1, improved tissue penetration due to low protein binding, lesser risk of convulsions, post-antibiotic effects, low risk for drug-drug interaction compared to meropenem. The place in therapy. Carbapenem is a novel parenteral carbapenem which has an antibacterial activity recently approved for use in India. Carbapenem exerted a greater bactericidal effect than other carbapenems on Pseudomonas aeruginosa. Carbapenem suggests that the drug could be a new therapeutic option against infection, with imipenem producing carbapenemases producing Entobacteriaceae. Carbapenem has shown clinical and bacteriological efficacy in treatment of wide range of serious infections. Seizure potential is lower than meropenem and imipenem. Carbapenem is likely to be the greatest value as empirical therapy, but when we are talking it to use it as an empirical therapy, they should provide the sensitivity disk to the microbiology department of the hospitals. So when the antibiogram comes or when the report of the culture sensitivity comes, it should show that Carbapenem, like we see the meropenem resistance or the Biopenem resistance, it should reflect. So I will request Cadila people to work on this front with the microbiology department of the hospitals, provide the sensitivity discs, so the people should start seeing in the report that Biopenem is a molecule which the hospital is doing sensitivity, and compared to others, this is where the clinician will get a first-hand information. Yes, the molecule which I plan to use is really good. I am going another conference in December, which is our annual conference. This time Gasparini from Stefano. Gasparini is coming from Italy. He has given his consent. He is the master of interventional pulmonology in the country. And it is a craze for the chest specialist to get into the IP field, because we never want our physician's friend to give us asthma or tuberculosis or COPD patients. They are competent enough to treat. Where they stuck, we excel there and we come to their rescue. Now, to put what I have talked into discussion, my moderator friends, Dr. Ram Babu, he is vastly experienced in treating the critical care patients, with Dr. Rajiv Diwan, who is, both of them are with me in Jaipur Golden and Saroj Hospital. And we have another senior physician with us, Dr. Vikas, and Dr. Rajiv, who is head of the medicine program for previously in Sundaral Jain and now in CK Birla group of hospitals. I think they will actively participate, and Professor Arun Madan, Dr. Rajesh Sharma in our surgical department. So in patients of, rather than getting into this, what do you think after listening this talk about this molecule? Yes, Dr. Rambam, what do you think about this? I know we have no experience of using it. So what do you think about?
First of all, I chairing a session, and congratulations and thank you, Dr. Chawla, for wonderful delivery talk about the newer molecules of Carbepenem, the Biopenem, and he briefly and told about the pharmacokinetic and the use and what the other side effects of the molecules. Definitely, this is the newer molecules of the Carbepenem have a wonderful effect. I have also using these molecules for last 3-4 months of other have the definitely good result over the other Carbepenem. Okay, but request to all of you, this is a newer molecules and have a broad spectrum of the gram positive as well as gram negative coverage and anaerobic coverage. So please use judiciously this molecule. Otherwise, we will also lose this molecules as a and go for the resistant and develop resistant.
So
In
this
the
is,
last,
this is where
yeah,
it
yeah.
comes an appropriate use
of the
of
judiciously.
antibiotics. Correct.
In last 2 years, we are facing lot of problem regarding the COVID, then COVID patient COVID से तो हमने बहुत सारे बचाए सब कुछ, लेकिन definitely they land in the secondary infections, and secondary infections. So patient being gone on land on the ventilator, extubated in the ventilator, then but the Klebsiella and the Acinetobacter in our ICU, there is the deadly infections. So when we gave the lot of the Carbepenem, Meropenem and the other, but there is no response. We are helpless. I so many times called Dr. my mentor and my boss, Dr. Rajiv Gupta, sir क्या करूं? तो सर ठीक ही नहीं हो रहा पेशेंट मेरा, मैंने कोविड वाला पेशेंट पार्ट टाइप ठीक है, मेरा डी डाइमर ठीक है, एवरीथिंग ठीक है, पर मेरा पेशेंट सेकेंडरी इन्फेक्शन से निकल नहीं पा रहा है. कहता यार जैविसेप्टा दे दे, जैविसेप्टा दी so many times, but we are helpless. But this is definitely wonderful molecules. As per cost also, this is not so big issue. We can tolerate our patients. So this is have the broad spectrum of gram positive, gram negative, and Acinetobacter as well as the Klebsiella. So request to all of the wonderful molecules, but not should be in the first line. It will be after the sensitivity test or the second line or reserve medicine for the deadly infections. Otherwise, we will lose this also infection. So this is definitely wonderful molecules. As per my opinion, I am using this molecule for last 3 to 4 minutes. पहले ये 2-3 कंपनियों का लॉन्च हो चुका है, जिस आई यूजिंग have the good result.
Good. Thank you.
And the safety profile also good.
Thank you.
Thank
Rajiv,
So-
how commonly when you are doing ICU practice and you are starting empirically upfront antibiotics, with your experience, what is good for the patient, how many times you have experienced the carbapenem resistance? Because all of us are keeping carbapenems in the pocket when we are treating the patient. So how many times your experience is before you take out this patta of ACE to use and patient has got a carbapenem resistance and you are lost? How many times it has happened, and what is the incidence in your ICU of the carbapenem resistance?
Yeah. Actually, I tell you one thing. Drug-resistant Klebsiella and Acinetobacter, they are the #1 killers in ICU nowadays. I will put Klebsiella above Acinetobacter because most of the isolates, I'm talking about Suroj, I don't know whether, most of the patients who are dying, they are dying of multi-drug resistant Klebsiella. And small percentage of Acinetobacter is becoming. Acinetobacter, I have seen that more than 50% time they're resistant to all the drugs. And in Klebsiella, I'm finding at least 25 to 30% in cases they are resistant to all the drugs which are available. So this drug appears to be very promising, and at least we can save some lives, because otherwise it's very difficult when we encounter these drugs and we almost sign the death certificate. I'll tell you, because all they're resistant to all the drugs. We do not do not know how to give what to treat, how to treat. So this drug provides some hope, at least in these patients. We can provide relief to the patient and save some patients, because they are the really life-threatening infections. Klebsiella is #1 in Suroj Hospital. They are #1 in isolates in the ICU settings, particularly the ventilator-associated pneumonias, secondary infections. We grow Klebsiella. Sir will agree with me. You must be also saying. And then 25-30% patient will having Acinetobacter. Then there are fungal infections and other things. So if the drug works, I have no experience personally with the molecule, but if the drug proves effective, it will be boon for us in ICU.
So we hope this molecule is a ray of hope to help us out.
Yes, yeah,
Right.
As per the review, very nicely done review,
Right.
it appears to be promising drug for those patients.
So Dr. Vikas, he is a senior medical officer and doing his practice. What are the common organisms you come and encounter for these community acquired infections or the pneumonias?
Sir, basically, I am treating general as a physician. Most commonly, if patient is very sick, first I refer Dr. Chawla or senior consultants or admit in hospitals. This molecule is very good, effective. Dr. Chawla said how is effect in UTI or different various studies. I definitely agree with Dr. Chawla and Dr. Rambabu also. He is using this molecule 3 or 4 months, because we are not treating in ICU or not working with the hospitals. But I really agree, if this molecule is working in patients, good results. Thank you.
Thank you. Rajesh, being a surgeon, you come and encounter around the patients of UTI. How you see this molecule, Biopenem, to be used in your patients who are complicated UTIs and in your surgical practice? Because urosepsis is very common in surgical practice. Where you place this molecule, what you look forward that you keep in mind that after attending this, you will use it and you have in mind, yes, it may looks promising in your practice.
Definitely, this molecule can be very useful and effective, but definitely in complicated UTI as well as sepsis, septic condition in surgery, which we find like we encounter in some trauma or perforation, peritonitis, and other infective condition and sepsis. Definitely, we cannot use empirically as a first line of drug, but many times we get patients who are already treated elsewhere and come to us in a very serious condition. And definitely, then the role of we don't find anything. Most of the other drugs which are available has been available here are resistant. This can be very promising and hopeful. I am hopeful that that can be very useful in our practice. Definitely, we would like to use this drug, and definitely I think it will be nice for our patients.
Thank you. Thank you, Dr. Rajesh. So I think sensitivity discs available in microbiology department for Carbepenem visible in the antibiograms, which released from the hospital every month, and the culture reports are going to bring this molecule in the mind of the physician. Rajiv, he is the chief of CK Birla Group of Hospitals. After listening the talk, Rajiv, where you see its place apart from UTI, for which government of India has recommended it, but people abroad, Europe, they are using it. How you look from your point of view this molecule?
See, I'll be little more even outdated. See, as far as I understand, this molecule is at least as good as Meropenem. At least as good as Meropenem. However, the study which I went through showed some funny situation. You know, Meropenem was used in 500 mg 3 times a day, and Carbepenem was used in full dose 300 milligram twice a day. Normally we use Meropenem 1 gram 3 times a day. Right. So little dosing issue was there when I saw the trials. And second thing was it was slightly inferior when we talk of enterococci and gram negative and staph is negative. Two areas where this molecule was little down as compared to Europe. So I will put it at par with Meropenem. And say we have extensive experience of using Meropenem for last more than 15 years now. I will be little cautious in using a new molecule. However, whatever you have presented gives me more confidence of using it in future in particular places. Now that case would be, as you say, complicated UTI with septicemia installed. I am more worried about that particular spike. We lose a lot of patient of that, right? More than 50% die if we do not use the right antibiotic. That means proper use of antibiotics, particularly empirically. We use in that situation which are like it. There we have a role for these molecules, plus minus something more. Because I tend to be more comfortable now, after seeing a lot of Meropenem resistance, to use Ciftazidim plus
Tazobactam.
Tazobactam, penicillin Tazobactam, and Ciftazidim plus
Avibactam. This was the molecule in COVID time used maximum by Medanta people. It was not available in our hospitals. Where is available Medanta? Who is using the Department of Intensive Care? Correct. Correct.
This molecule for 3 months, change to new molecule for another 3 months. So just to maintain the sensitivity pattern, we do antibiotics.
This is another way of the antibiotic appropriate use.
Klebsiella as well as Acinetobacter. There is no hope. I am very helpless. I have good amount of the patients, sir, you know, at the COVID time, dengue time, they have the treatment, so many cases of the, yeah. But after infecting with the secondary infection of the Klebsiella, this is the multi-drug resistant, which is the important bug, most common deadly bug of the Jaipur ICU. And then previously Acinetobacter. There is no Javisepta, Acino and Carbepenem tabhi aaya hai, and Meropenem, all are the no. Both are very helpless.
Polymyxin B.
Polymyxin B. I'm also very fond of the polymyxin because of our patients are not tolerating the cholesterol, and cholesterol and the polymyxin have the both same spectrum of the antibiotic. So I'm very fond of the polymyxin, but definitely Klebsiella and multi-drug resistant have the lot of
it is all right. It's well taken. Let us see Carbepenem.
So
and we have some ray of hope.
We hope the best for the.
Now I know the dinner is getting delayed. There are online questions about difference between Meropenem and Carbepenem. It is equally superior. It is not inferior to Meropenem. So you can always have a faith on this newer molecule, which is approved by Government of India. It is effective against intra-abdominal infections like acute pancreatitis. Yes, it should work. These are online, the audience, for the benefit of the audience, I am answering. So it is equally effective in acute pancreatitis, and you can use it without any issues. Right. So they are appreciating regarding the program. They are welcoming you all in Delhi, sitting in various places in the country. Thank you very much, the audience. We are also welcoming you. Thank you very much. So okay, thank you. Thank you.
Wonderful. What a great evening. I'm sure that was a real wonderful, insightful session by Dr. Rakesh Chawla on the newer Carbepenem, which has been there for the management of different kind of infections. As he rightly said, this molecule is not a newer molecule globally. This was been available, but on patent, but off patent now this molecule is available for use in India as well. Thank you so much, Dr. Chawla, for giving this insightful session, which has given insights about the molecule. The first antibiotic, all of you know, was launched long back. It was discovered by Alexander Fleming. After that, a lot of antibiotics came, and each antibiotic has definitely its own characteristics. And that's how that has been got used in different kind of infections. So this is how Dr. Chawla has elaborated on this molecule, and this is found to be useful in different kind of infections. Thank you very much, Dr. Rajiv Diwan and Dr. Rambabu also, and the audience for giving their opinions and feedbacks on their experiences and on the usage of this molecule as well. With this, I thanks all of you for attending this session, and will request you for go for dinner and the further proceedings. Thank you so much.